St. Methodist Neurological Institute and the Stanley Abel Neurology Department. She's the primary coordinator for multiple trials exploring therapies for acute stroke recovery, diagnostic imaging, and secondary stroke prevention. And with Criswell.
Thank you. Hopefully slides will not crash. All right, so we're going to make this a little quick. I'm going to be discussing overcoming challenges in clinical trial enrollments. There we go. Thank you. Okay, so obviously challenges in clinical research are going to differ by study phase. For today's talk, we're going to discuss randomized controlled trials. Oftentimes it is cited that subject recruitment is the most challenging aspect of clinical research, which is interesting, right? So within clinical research, it's not as simple as finding someone who's agreeable to participate, even though that desire to participate should be a driving factor behind everything that you're doing as part of that research team. And the majority of research, which is outside of stroke research, most patients are approached actually by their primary care physicians, which is not true in stroke. And so we're going to start with acute stroke research. So principles of research best practice are often centered around clinic-based trials. And clinic-based trials have different needs than what you're going to be seeing with patients who are coming in that immediately need to be treated. So acute stroke trials present unique challenges that aren't found in those other disease categories. To demonstrate this, we're going to follow a hypothetical stroke patient from arrival to outpatient. The research team has been alerted by the investigator that we have a patient who may be eligible for multiple trials. So just as the stroke injury progresses, so does the patient and their opportunities to participate in different types of stroke research. Screening. So first thing, you have someone who's agreeable to participate, but they also need to be eligible. So a big question we have to ask ourselves is, one, is that patient able to meet the primary endpoint, or can the primary endpoint be met with that patient? Trials cost multiple millions of dollars, sometimes $1 billion from bench to bedside to produce, and it can all hinge upon one single question. That's a lot of pressure, right? So some universal primary endpoints include all-cause mortality, serious adverse events, and of course expected adverse events depending upon what type of drug or device that you're studying. For example, bleeding events with thrombolytics. So after screening, we have somebody, they may be eligible, we're going to consent. I actually had a lot of time dedicated consenting because it's one of the most difficult aspects of enrolling a patient in an acute stroke trial specifically. Because stroke severity differs, the majority of the time in acute stroke trials, you're going to actually be consenting with a legally authorized representative, which is going to be a family member, next of kin, power of attorney of that patient. During that process, of course, if your patient is able to consent for themselves, or to determine that they are allowed to consent for themselves, you will have to get the consent from them as well, even if you obtained it originally from their LAR. So challenges that are faced in that small time window when you're trying to very quickly treat a patient, oftentimes are language barriers or physical distance. So at least at our institution, a very sizable percentage of acute stroke patients that qualify for thrombectomy are actually being transferred here from community hospitals. So that means that the patient is here, but the family is not. Like I said, the majority of consenting expectations in most of research is under the assumption that you're going to be seeing somebody face-to-face at a scheduled time within a clinic. Wouldn't that be wonderful? That's not the case. And so depending upon the institution that you're at, most of them will create SOPs to specifically address consent variances that occur because patients or their LARs will not be with patients whenever they arrive. So some consent requirements. Consenting has to occur under circumstances that provide a sufficient opportunity to consider participation. That's sometimes difficult. We'll go back to the endovascular suite. Sometimes that investigational drug needs to be delivered before groin puncture, which doesn't give you a lot of time. But despite that, you still need to have understandable language that also means language that is both in readability and in the native language of whoever it is that you are consenting. Something to take into consideration is that around 1/3 of adults in the United States are considered to have a low literacy level. And so that includes, obviously, understanding of health and medical terminology, but also even in quantitative literacy. So showing a chart isn't always going to make sense. Explaining that somebody has a 50-50 chance will make sense to the majority of people in here, but not always whenever you're under stress. And so using phrases such as flipping a coin makes something that's a little more tangible for people to understand and visualize so that they know what you mean when you tell them 50-50%. During the consent process, it's important to note per FDA that it's actually prohibitive to claim that any sort of investigational drug or device are safe or effective for the purposes for that they are being investigated. Instead, the way that we describe this conversation is that we discuss potential risks and benefits, and that's to try to get out of any sort of influence that someone may think this is safe just because somebody in a coat is talking to them about it. Per those FDA guidelines, some things that have to be discussed during the consent process, of course, is the description of the clinical investigation, those risks, discomforts, potential benefits, and then alternative procedures and treatments. An important thing to note with this too is sometimes there is no alternative. Confidentiality, compensation for medical treatment in the event of injury, contact information that includes for the PI, research team, for the IRB, anybody that they would need to reach out and talk to about the clinical trial. And then of course you need to emphasize the fact that participation is always voluntary and that no changes are going to be made to their standard of care if they choose not to elect to participate in your clinical trial. Additionally, if it's appropriate, you can discuss unforeseeable risks, what it means to be, why you would be terminated from participation early if you're a subject, any additional cost to them, consequences if they were to withdraw early, that you will provide any significant new findings to subjects during the course of the trial, and then also the number of subjects that are being enrolled specifically at your site, and then also across all the sites that are participating in the trial. All of that said, we are now admitted. So, hyperacute and acute trials. Location that we're going to find the majority of these at, we're going to be in the mobile stroke unit, we're going to be in the emergency room, we're going to be in the endovascular suite. So challenges, of course, like we just discussed, we're consenting. That was a lot of information, and you're also trying to convey it to somebody who's pretty stressed out at the time period, right? Randomizing and enrolling while understanding time is brain, of course, is important. There's a lot of metaphors to describe what this feels like, but the one that is coming to mind right now is sometimes you feel if your research protocol is a rock that's being tossed into a stream, right? You're going to divert flow, but the stream is going to continue going. There's no stopping it. And so it's your choice to decide how it is that you're going to be put into that situation so that you can do the protocol requirements. You know, it's important too that, and this extends also to the ICU and the stroke floor, that you have in-services, that you meet with staff, that they get to know your face, right? And so it's not a question of, oh goodness, there comes the research team. It's like, oh, there's Amber. We saw her 2 weeks ago talk about this thing. Let's chat with her, right? So challenges that can also occur, even though we're out of that really hyperacute and acute time window, is weakened coverage, adherence to standard of care versus core measures versus a research protocol. So to reference back to Dr. Chimowitz's talk earlier in his discussion of the Captiva trial, let's say that we enrolled somebody in Captiva whenever they are inpatient here, and they're being discharged, and they have already been randomized to receive one of the investigational drugs, right? And for whatever reason, that drug would be contraindicated. A regular drug that they would be discharged with would be contraindicated per the protocol. And that might sort of conflict with what they would be receiving as part of like their core measures. So if a patient is enrolled in a clinical trial, if they are not meeting some specific core measure, that's actually not going to count against you. And so that's really important to note. So we're at discharge. Follow-up expectations, right? Following behind recruitment, patient retention is seen as one of the most difficult aspects of running a successful clinical trial. Of course, you had a family, they were happy, the subject was happy, I want to get better, I want to get well, now I want to go home. Don't call me, right? This is why communication is important. Regular, consistent, expected communication with research subjects is absolutely essential, and this is a really big part of what research coordination is, right? We will be communicating with that patient before they leave what's to be expected. In a majority of stroke trials, we're going to be seeing patients and follow-up as part of clinic. We're going to see them maybe 30 days, 60 days, 90 days, possibly 365 days, and all of those visits can be scheduled before they leave the hospital, which is pretty essential. And outpatient. Outpatient clinical trials follow models that are more closely related to the vast majority of clinical research. They follow schedules, obviously non-acute in nature. The adherence to time windows is pretty strict whenever it comes to outpatient clinical trials, even though those windows might be a lot bigger. And then of course, device and drug trials are often focused on secondary prevention and outpatient settings. So clinic-based trials, they often last for years, 5, 6 years, and you're explaining to somebody that I'm going to be seeing you for that long of time. So recruitment efforts can extend to advertisements, social media, partnerships with those primary care physicians like I was discussing earlier. It's important to establish that early because those expectations are really big, because once again, someone might be really excited at the beginning of a trial, but keeping up that excitement is difficult. It's helpful when you get on a first name basis and they get very used to hearing from you. It's establishing those expectations I was talking about earlier. Something that's coming down the pipeline, well, it's already here, but is becoming more regular, are decentralized clinical trials. So born out of necessity during the height of the COVID-19 pandemic, obviously the use of telehealth was rapidly adopted, and that includes in clinical trials in stroke. And this is especially relevant because when I was talking about primary endpoints, the most common primary endpoint in the majority of stroke trials, whether acute or outpatient, is actually, with acute stroke trials is 90-day MRS, the modified Rankin scale. And modified Rankin scale is something that could possibly does not necessarily need to be obtained in person and could be done over a video visit. And so you certainly wouldn't want someone not being able to travel in or missing a visit or getting outside that time window, when really what you essentially need to capture is that MRS, whether it's at 90 days or 365 days. And so what's important is whether you're designing an investigator-initiated trial or you're at the point you're establishing expectations with a industry-sponsored study, that's very important to open up the conversation about where telehealth fits into the protocol, because something that I've noticed with Study Startup is that while the protocol does not specifically include that this is something you can do, it doesn't exclude it. So are you a protocol fundamentalist, or are you someone that's reading a little bit in between the lines and having that conversation to say, this is something that we'd like to do? And I see that this is going to be a trend that I don't think is necessarily going anywhere. So the adoption of telehealth in research is incredibly important for the future. These are my references, and thank you very much.